All right, it's 1 o'clock. We'll get started. Thank you everyone for joining us here today. My name is Michael Cooper. I'm Vice President, Mental Health Research Canada, and I oversee the data collection work that we do here at MHRC. We've been collecting data for quite some time, and we were really pleased that we were able to partner with several organizations to collect some information pertaining to eating disorders, which we'll be sharing with you here today. Again, this is my colleague Brittany is overseeing the forward progression of the slide, and we can go ahead. So we'll start with hold on, I got it here. We'll start here with the land acknowledgement. I am here in the Caledon area, which I acknowledge the lands that can constitute present day Caledon as being part of treaty and traditional territory of the Mississaugas of the Credit First Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Wendat nations. We recognize these people and their ancestors as people who inhabited these lands since time immemorial. And I, of course, realize that many of us are on different areas, and you may have land acknowledgements for yourself as well, and appreciate that we can acknowledge the ancestral lands that belong to the historical First Nations, Inuit, and Métis people. Moving on. So I'm happy here to be joined by Wendy, Shaleen, and Nicole. Just to give you a quick heads up as well, this is a sensitive topic. We do realize this might be triggering for some individuals. It is being recorded. In terms of questions, you can post questions into the chat function. We are seeing those chat functions, and if we need to, we can unmute you to ask a question directly. The chat is actually being managed by my colleague Brittany and Rianne, who are monitoring the chat for us as well. And I'm pretty sure our panelists are following this rule as well, which they are on camera, but turn on your mute microphone when appropriate. And of course, we'll make this available afterwards as well as the report as well. We often circulate a feedback form afterwards. We've done many of these webinars, and we continue to evolve and update them based on the feedback we receive. So thank you so much for any feedback you could provide afterwards. Next slide, please. So I'm just happy to share that we do have a number of resources we've made available for eating disorders. This has been a topic that we have covered in the past, and we funded research in this space before. So here there is a list of some resources you can download from our site, and I'm sure my colleagues here on the call have additional resources that they can speak to as well. Actually, before we move on, Wendy, Shaleen, or Nicole, is there anything you'd like to add as a critical resource? Do we have their website listed? I don't know.
I would add the National Eating Disorder Information Center, NEDIC, as another resource for folks. They're our national organization for information.
Shaleen, go ahead. You don't have to put your hands, it's just 4 of us.
I just put the link to Eating Disorders Nova Scotia and Body Peace Canada. Body Peace Canada is our national peer support program, so folks anywhere in Canada can access those resources.
Wendy, any other resources you'd like to share as well?
Sheena's Place is a really excellent resource for caregivers and those suffering with an eating disorder. They're downtown Toronto, but they also do programs online.
Fantastic. Thank you so much. Moving on to the next slide. Again, my name is Michael Cooper. I'm the vice president here. I do not know a tremendous amount about eating disorders, so I am approaching this from the perspective of someone who wants to learn. I am our in-house data nerd and geek, so I'm good at parsing the numbers and good at somewhat good at project management, but I'm actually looking forward to learning more about eating disorders here today. Nicole here is joining us. Nicole Obeid is joining us from the CHEO Research Institute, and she is the scientific lead of the ED Research Lab. Shaleen, who I've worked with for many projects and known for quite a long time, is the executive director of Eating Disorders Nova Scotia and Body Peace Canada, who I had the great pleasure of hanging out with for the last week for 3 days, well caffeinated at a conference. And Wendy Preskow, who I understand has been involved with my colleagues Barani and Aquila, part of a research grant that we've provided as well. who's the founder of the National Institute for Eating Disorders, is here with us as well. Thank you for joining us. The next slide. Yep.
Hi, Michael. Sorry, I just wanted to pop in and say that we do have some time allotted for our guests if they want to take a few minutes to talk about their organizations.
Thank you for
Just before we
clarifying.
dive into the findings.
Thank you, Brittany. Let's start with Nicole. Do you want to tell us anything about the CHEO Research Institute and the lab you lead?
Hi, thank you, and really nice to be with all of you today to chat about some of the data that we found. So I'm Nicole Obeid. I'm a scientist and experimental psychologist by training, and I head up the Eating Disorder Research Lab at the CHEO Research Institute here in Ottawa. Our lab is really focused on understanding health systems work and really interested in early intervention specifically. And so screening is a big part of that. And we're really interested in seeing how questions like we posed in the survey can also be used at a population level for us to understand the state of eating disorders and some of the work that our lab is leading. Thank you.
Shaleen?
Hey everyone, so my name is Shaleen Jones, and I'm the executive director at Eating Disorders Nova Scotia, which is a region-specific organization. We started out just serving folks impacted by eating disorders within our province. We support families through our peer support programs. We have clinicians who work with clients. We have workshops and education sessions, and really trying to help people access the supports they need, because we believe that everyone should have access to the resources that they need for recovery. And so we work to kind of connect people and to smooth that path. A few years back, we wanted to expand peer support across the country so that folks from coast to coast could access the peer support programs that we have. And so we created Body Peace Canada. And through that program, folks can access a variety of like self-directed learning, videos, workshops, and peer support programs, including groups and our one-on-one peer support program, all of which are delivered by trained peer mentors. So I'm really excited to be here today and talk about the data, and really thank you for opening this conversation up and getting this going.
It's a pleasure. Wendy?
Hi, everybody, and thank you for joining, and thank you very much to the MHRC for including me in this conversation. I am the founder of the National Initiative for Eating Disorders, which I started almost 13 years ago. We have a daughter who has been suffering with an eating disorder for 25 years. And one of my passions has been talking to other caregivers who are so overwhelmed and feel so unsupported in their role looking after somebody with an eating disorder. I'm really sort of touched and happy to say that when I started the organization 13 years ago, our daughter was really in a very, very bad place. But today she's different, and she's got a sparkle in her eyes and looks different. And I just keep hoping that she's able to put one step in front of the other.
That's fantastic.
Thank you.
I realize that there are probably people on the call who don't know what we do either. So very quickly, Mental Health Research Canada, we do grants and studentships, and then there's the work that I oversee, where we've been collecting mental health indicators since March, April 2020 at the start of the pandemic, in partnership with our funder Health Canada, who has allowed us to collect not only the mental health indicators, but really look into intersecting issues. And so the genesis of our 21st collection, which we did over the summer, was we looked into issues around social media, we looked into our standard mental health collections, and then we had some space. So we were happy to work with Shaleen and Nicole in actually working out if we could put some data in there pertaining to eating disorders. Having a rough understanding that there was a lack of data available at a national scale for eating disorder prevalence. And then we went through a process of trying to understand what was the best screener, what was appropriate for the methods we were collecting. And we were happy that we were able to put in those questions and address some underlying issues of eating disorders. My colleague Brittany mentioned at the start, before many people joined, but our data project, again, we have over 65 data partners that we turn the data over to at free of charge. We've published close to 100 reports on our own, and there are hundreds more that have been published or articles written about this data. It is now one of the largest, most comprehensive data sets looking at both mental health and the issues that intersect mental health. And we're really pleased to lead that project, and that we were able to lend some space in it to eating disorders so that we can understand a bit more about this issue. Next slide, please. So just overall, we always spend a couple minutes talking about the overall findings that we have in our poll 21. So as I mentioned, we did look at eating disorders. We found approximately 1/3 are at high risk of developing an eating disorder. We found that that was higher for Canadians under the age of 35. We do start at 16, so that's 16 to 35. And we did note that it was higher for members of the 2S LGBTQ plus communities, more likely to be at risk of an eating disorder. We also were able to correlate that with looking at severe symptoms of anxiety, nearly double the rate compared to the national average. And again, double the rate of severe, these would be on clinical screeners, PHQ and GAD. Higher, almost twice the rate of suicide, and over 2 times the rate of planned attempts as well too. We also see correlations with alcohol and cannabis dependencies, which are based on the audit and cut-it scores, which were provided to us by the Canadian Centre for Substance Use and Addictions. We also had other findings in there as well. We did look at social media specifically. We'd done previous research that looked at over 6 hours of screen time was especially for young people, a precursor to very negative mental health indicators, including suicide ideation. So we looked at specifically what were the things people were doing on social media that actually were driving negative mental health indicators. In terms of FOMO, fear of missing out, comparing themselves with others, cyberbullying, and pressure to maintain a certain image. And of course, these were all higher for young women over young men as well too. So yeah, next slide, please. I think there was some good news in this as well too. We found that the rate of people accessing mental health in the past year has been slowly rising for the last 18 months. It was up at about 20% or above during the pandemic, and then fell way back down to around 10, 11, 12% shortly after the pandemic in 2022. But every quarter we have seen a consistent rising trend of people accessing mental health supports. And this could be concerning, and certainly you could look at it that way, but our general takeaway is that levels of satisfaction of care are also going up with it. So not only are more people accessing help in mental health, they're more satisfied with it than ever, which means that that help is actually good. It means that they're reaching out for help and they're getting the help they need. So this increased capacity that we're seeing in mental health is actually a really good story as well. So I'm feeling pretty good about that. And then we looked at mental health improvement over the past year. More people said their mental health has gone up in the past year, and a population of people who have gone down, the 19%. We do tend to note that those are more connected to economic stressors. Has been a significant correlation with the number of people who have worsening mental health indicators as well too. Again, financial struggles, substance dependency, physical disabilities, 2S LGBT are more likely to report a decline in their mental health as well too. One thing I'd like to point out before I missed it here is that people who are getting help are more likely to see an improvement in their mental health. So we are seeing that the people who are acknowledging they have a mental health problem are more likely to actually see improvement. So that's good. It's correlating need with actually getting the service they need, which is really positive. The services are getting better. One thing we'd like to talk about as well is mental health literacy. We've done a lot of work into mental health consumption, mental health literacy, the depth of that literacy as well. And one simple question we asked this time around was, what percentage of Canadians are confident in their ability to recognize signs of poor mental health? Only about 1 in 3 Canadians are confident and are very confident in their ability to identify when they're struggling with a mental health issue, which means conversely that about 2/3 are only somewhat confident or below, and they have room to go to improve in terms of recognizing mental health. So this is, again, tied to literacy. We need to do a lot more in this space as well, too. Also tied to self-stigma as well. Next slide, please. So at this point, I'm going to move on away from our overall findings. If people are interested, if you go to our website, mhrc.ca, go to our work under national polls and research, you will see dozens and dozens and dozens of reports we published either at a point in time or deep dives into specific issues. There's also an interactive data hub there. If there's a mental health question that's been asked, there's a reasonable chance we have at this point answered it or addressed it or at least studied it or looked at it. And we're really proud of the body of work we put together. So if anyone wants general mental health indicators, by all means, check our website, reach out if you have questions. If we haven't answered it, there's a good chance one of our partners have. So moving on to the specific eating disorders component of that, unless there's critical questions. Rhiannon or Brittany, are there critical questions in the chat that I should address before I move on to the discussion on eating disorders?
Hi, Michael. Nothing coming up so far. We are making a list so we don't miss any at the end. But I think at this point, we're okay to dive into the discussion, and we'll make sure that any that have come up to this point and will come up throughout will be addressed.
It's worth noting that Brittany's been on this project almost as long as I have. So she knows this data inside and out quite well. And she typically leads these webinars as well. She is an incredible human being, a fantastic moderator. And you are unfortunately stuck with me for this particular one. Moving on to the indicators. Can we move on to the next slide, please? Thanks. Oh, I guess we're just going straight into the questions. Okay, so I'll kick us off then. So I'm just going to open the question. I'm assuming all the moderators have actually seen the data in question that approximately 1 in 3 have high risk of eating disorders. I'm wondering whether or not you could tell me what surprised you about the data. I'd like to start with Nicole, since I think you provided the initial screener that we looked at. What surprised you about it?
I guess I had to be honest. I wasn't quite surprised with the number that were at high risk. That really corresponds to what we see and feel clinically, especially since the pandemic, where those numbers feel like they got higher and stayed higher, and they've been high ever since. I think what's really intriguing and interesting for us to have is that we have such little data available for eating disorders in Canada, and the ability for those intersections to be shown with this data to show that those that are in younger populations have higher risk, those in the LGBTQ2+ category also. So some of that data, and then to show the other mental health comorbidities and show how much of an interaction eating disorders have with all of these other mental health symptoms is a first in Canada, and really relevant for us to be talking about not only how prevention, but treatment interacts, so that we can really treat a whole person or think about a whole person and not the eating disorder separate from all of these other concerns that are also very prevalent in our Canadian population.
I have questions back at you, but I'm going to open the floor to Shaleen first before I follow up with another question. Shaleen?
Yeah, really to echo what Nicole's saying, I think I've been working in the field since '96, and we've been talking about this crisis in care and the gap in resources across the board for 30 years. You know, when I started out working in this field, I bring lived experience to this. Resources were very scarce. And unfortunately, here we are 30 years later, not a whole lot has really dramatically changed in the field of eating disorders in terms of resourcing. And we look at some of the challenges that we faced during the pandemic when, you know, we were kind of in a crisis situation with eating disorders before. And then with the pandemic, seeing those really significant spikes in especially with young people getting really sick and not having access to the resources, I think it really revealed an incredible disparity we have in how we resource, train, educate, how we work with eating disorders. And like Nicole said, those numbers have not come down back down pre-pandemic numbers. And community groups like Eating Disorders Nova Scotia and NIED and NEDIC and all the rest, we continue to do our best to support people where they're at, with really limited funds being available, despite how common these illnesses are. So that was my takeaway.
Thank you. Wendy?
Well, when our daughter, her name is Amy, when she first got sick 25 years ago, it was like a bomb had been dropped on us. We had no idea where to go. There was no internet, there was no Google, there was no cell phone situation. And at the time, I know that my husband was working downtown, and he literally ran down to the NIED office to try and get some information for us, and came home with piles and piles of paper. And I clearly remember just sitting on our bed and going through all this paperwork to find somebody out there who could help us. And I think I can sadly say that when caregivers call me, and I have heard from everybody, whether it's a husband, a grandparent, a sibling, a spouse, a common law spouse, I almost feel that they are in the same situation today as I was 25 years ago. They still are so desperate. They are still looking for so much help. There are still so few people who are really qualified and expert in helping people with eating disorders. So I can so identify with other caregivers when I get the calls, because that's exactly how I felt 25 years ago. I mean, thank goodness today we do have the internet and we do have, access for people to look things up. But as far as help and support and diagnosing the eating disorders, it still feels like we are very far behind. And eating disorders, they just, I think even, I remember taking Amy to her pediatrician and him saying, that you have an eating disorder, but then what? What are we going to do about it? So it just feels yes, the needle has moved a lot in mental health. I'm not disputing that at all. And thank goodness, in a way, for COVID, because it brought out so much. But on the other hand, I still feel, and in the calls that I get, I still feel that we are very far behind where we should be 25 years later.
Thank you. My follow-up question. So I am a data nerd. I know what data exists for eating disorders. I've seen some information. StatsCan has done a limited amount of work in terms of trying to understand this. But where my conundrum comes in is whenever I see any sort of question, have you been diagnosed with an eating disorder? It's a very complicated question for me, because I've seen indicators that indicate that it is a highly undiagnosed condition. And so if I were to ask somebody, are you diagnosed with an eating disorder? They would say no, but they could still have an eating disorder, which is why it's a very difficult thing to track. So again, then we approach this not from the perspective of, can you tell us if you have an eating disorder? Because we have that number. We know that a huge number of people are showing symptoms of or risk factors for eating disorders, but are not indicating they're diagnosed. And we can track that separately, which is why we approached it from a screener perspective. And then, our challenge was we weren't confident in what screener to use to actually identify these risk factors. We know that there's a general agreement on PHQ for depression. We know there's a general agreement on a clinical screener of GAD for anxiety. Can you explain to me, and I know we've had this conversation because you've had to explain it to me, so to put it in, a little bit about the ODESY, the ODESY? I don't know if you regularly speak it as just the letters. I don't know how to say that, actually. I know we included it, but I don't know how to say it. Can you tell us a little bit about that screener, just so that everyone can understand how we got to 30% of people showing high risk on that screener? Sorry, that was a statement and a question.
No, that's great. So fellow data nerd, always glad to be in presence. So the Odyssey, as we call it, the Ottawa Disordered Eating Screen for Youth. I think you really hit it on the head there, Michael. When folks think about the prevalence of eating disorders, folks tend to think of anorexia nervosa and really only those that are diagnosed, and it's a small percentage. But what I think this data really showcases is that when you open that up and you ask about the symptoms, the concerns, everything that's pre-diagnosable, prodromal, there's just so many more folks who are struggling, and that's the number we really need to be aware of. Not just wait until there's a full diagnosis. There's so much more we can do ahead of time. And that's really where the Odyssey was born from. And so that's work that myself, the lab, and many of us, including Wendy and Shaleen from across Canada, have been trying to work towards, is creating an early intervention strategy for eating disorders. Because we know there's so many and there is no access to treatment. The Odyssey was born with trying to understand what that prevalence rate was. And what we did is to create the questions on the Odyssey, and it's a 4-item screener, we did quite a bit of homework in the background, asking not only practitioners, medical practitioners, mental health practitioners, but also young people and family members as to how we could create a screener that could actually be useful for this space. And the first piece of advice we got was keep it brief, and that's hard in the field of eating. It's sort of very complicated illness, so to have a brief screener is hard. When they said brief, they said 2 questions. We managed to push it to 4 with lots of resistance. And they said they wanted a brief screener that did not talk about weight, because weight was not a part of this for so many people, despite what I think is, sort of what folks relate to when they think about eating disorders. So they didn't want weight to be a question, which deviates from past screeners that have always had a weight question that's a part of them, which is hard for some folks to answer. And then they wanted a screener that actually communicated something. There's no point in us having a screener that just has a number and you don't know what to do with that number, but that it tells you that folks need more questioning, or they need to be have more interaction around those concerns. And so that was what was born for the Odyssey. The Odyssey also, following the advice we heard, doesn't only ask about the behaviors that are related to an eating disorder, but it asks about the thoughts, because we heard from our young people and family members that sometimes the thoughts are way worse than the behaviors, and that we needed a way to track those. And so the Odyssey has specific questions about the thoughts, which hopefully we can dive into, that allows us to tap into that huge population of folks who are struggling, and also gives us a window that there's something we can do. We can intervene if we know those thoughts are there, and how do we get there before they act on them and symptoms might become a part of the reality. So that was the Odyssey. That was where it came from. And I think what's, what you see in front of you, the 1 in 3, is so telling that the prevalence rate is so much higher than what we know about eating disorders. This is about disordered eating disorders, and everything associated.
Thank you, Nicole. I'm wondering if you could share anywhere people can get more information on the Odyssey as well in the chat, or anything along that lines. And I'll open the floor to Shaleen or Wendy. If Wendy, you went on mute first. If you have any comments on the high rate and the way we decided to go about looking at risk factors.
It just makes me think back to, had the Odyssey been around maybe when Amy was first diagnosed? And it's a bit of a hypothetical question, but maybe yes, it would have, because maybe then we would have had direction and been able to be told where to go and how to find the help that she needed. I mean, I do remember taking her to be assessed at a hospital, and at that stage, her anorexia was already established, and she was keeping herself on the right side of a very thin line so that she did not have to be hospitalized, which thankfully we never ever, I say thankfully, well, I don't know. We never had to do, we never had to pick her up and take her to hospital to be renourished or refed, the right terminology used. But I also think that knowing her personality and how she was, we would have blown up. I mean, I think there's certain, there would have been a certain small gap of time for us to maybe have stepped in to help her with her feeding and her eating, but it would have been very limited. And I think, I'm not sure, maybe Nicole can answer to this, but does the Odyssey also give an opportunity for parents to answer rather than just the person who has an eating disorder? Because I just think it's so important for any primary caregiver to hear from the parent's perspective of what is going on, because we know that these, somebody who's suffering from an eating disorder and they're hearing all these voices in their heads, telling them what to do, telling them what to say, that maybe it's not real enough for what the primary caregiver is hearing, and the parents' input is extremely valuable. So maybe Nicole, does the Odyssey, is there a page for parents?
You know, I think that's so important. And part of our training around the Odyssey, as we develop it and as we learn from folks like Wendy, is that the Odyssey could be a self-report. No doubt, if you have a family member who's actively involved, who the young person wants to be a part of their care, and that's the way that it works, that you would ask the parents, the caregivers, the person that they've chosen to bring those same questions and actually understand those perspectives from both. And there's lots of room for us to be creative with how that screening tool can be used, sometimes maybe just for parents if the young person is really in distress. So I think that's really up to the practitioner, the relationship they have. But if we thought about the Odyssey being screening, you know, population level screening, so every time you went to your doctor, potentially these questions are being asked, you have a relationship with that person, and hopefully you know who best to ask those questions to, because the parent perspective is so important, you know, for certain cases, and when you know that makes a lot of sense, absolutely that perspective is needed to help.
Shaleen, any comments you want to add on top of that?
So many comments, but I try to keep it. When it kind of jumped out to me was the importance, you know, of the early intervention part, you know, and I think we've come a long way in Canada on talking about mental illness as a brain-based illness. And I think we need to really be clear that eating disorders are a brain-based illness, they're a mental illness. So I think traditionally we thought of eating disorders as you know, affluent white girls who are looking at Instagram too much and need to eat a sandwich. And that seems to be the pervasive thought around who is impacted by eating disorders. And if people don't fit into that box, we don't tend to think about them in terms of their risk. And I was really pleased that the Canadian Pediatric Society came out with recommendations that all adolescents, regardless of weight, should be screened for an eating disorder. Of course, the Odyssey is a fantastic tool for that. But we really need to be looking at folks from marginalized communities, folks we don't normally think about when we think about eating disorders, knowing that anorexia is the least common of all the eating disorders. And you really can't tell who's someone who might be struggling with an eating disorder. It also really underscores the importance of early intervention. You know, and I feel like we cannot talk about this enough, that once the eating disorder has been allowed to grow in the brain, as it were, it becomes entrenched and very, very difficult to recover from, very costly to treat, very difficult to treat. And so being able to reach people before the illness and the behaviors and all that has become really embedded and entrenched, we were focusing on that. Those first couple of years from onset of symptoms is so incredibly critical. And I think one of the things we've done with Body Peace Canada is to frame it as a support for anyone who's concerned about their relationship with food, eating in their body, because we know that people self-stigmatize and they feel like, I don't deserve help. I should be able to handle this on my own. I don't have an eating disorder. I just have a complicated relationship, right, with food and eating. So to open that up and to encourage people to seek support at that stage without having to prove or perform illness, I think is really, really critical. And that's got to be part of a national strategy as we move forward to really focus on that early intervention piece.
Something I want to add on top of that, Shaleen, I've been working on a youth report, which will come out shortly. Surprise, spoiler alert. And the one thing we talk a lot about is this early intervention piece. And we've highlighted that eating disorders do have, as far as we can tell in the research, seem to indicate a prevalence, highest prevalence in that 15 to 17 corridor, which means that if we're trying to intervene, we need to start talking about how we're going to reach 13-year-olds, 14-year-olds, 12-year-olds, which means we need to be coordinating with teachers, parents, because, you know, it's hard to, these are not fully fledged adults yet. So we need to be working as well with the individuals around them, not just the individuals themselves, but think about ways we can get this information into the ecosystem around those 12 to 14-year-olds would be, you know, a great conversation to have. All right, moving on to the second question I have here as well too. And I think you've probably already answered this, but what didn't surprise you? What was something you fully expected and you got? Did 30%, it did surprise you? I think I heard that from someone. No, doesn't surprise anyone? I think I was surprised with the intersectionality. I expected there to be intersectionality with anxiety, depression. I was surprised with the intersectionality with substance use. I was not expecting that at all. And I think the thing that I suspect there are other nuggets in there that have yet to be mined. This is unfortunately something that we haven't done our deepest dive into yet, but I would be super curious to look at service access rates for those individuals. And there may be some interesting nuggets in terms of understanding a little bit as well, that gap between individuals who have identified it being high risk, and then some sort of a multi-regression analysis comparing those who have a formal diagnosis, who indicate they have a diagnosis, and those who have those same scoring on the ODESI, but aren't actually showing a diagnosis. So really trying to identify who are the groups and the people and the demographics that are most likely to be in dire need but aren't diagnosed. That would be a fascinating. So I think there's a lot of cool things that we could do with this, or hopefully other people could do it, because we got a lot on our plate too. But there might be a lot of really cool things that could be mined out of this. And I think that those intersections, I think the overall numbers didn't surprise me that much, but the intersection pieces, that's what surprises me. And I think that's the value in the data that we're providing. Is not just like, here's the overall number, but also from a policymaker standpoint, here's where you really need to look in order to identify these sorts of issues. I think that was something I was thinking about when I looked at it.
For sure. And I think another really interesting piece, that was another one of your intersectionalities that you pointed out, was that, for those that are at a high risk of an eating disorder, 57% of them also identify as food insecure.
Yeah.
And so that intersection is so important for us to be working with the many organizations and parties, that are helping and those affected. But how do we work together? How do we work together to create common strategy so that we can really be tackling all of this at the same time, versus, siloed efforts that don't do justice to the person in front of us?
And I think my next question here was directed towards Wendy, but I think you might have already answered it. But how would something like ODESI change the course of a patient's journey? If there was a system that could identify these risk factors, or what do you think that would have done for your situation?
I think it would have given us more direction. I remember when we left the pediatrician's office, and just remember, this is my experience. This was 25 years ago. She's 39 years old now, lives at home with us. And 25 years ago, so she was about 14, 15. And I think, had we walked out of that pediatrician's office with some information, not just go and find a psychologist or go and find a psychiatrist, we had no idea where to go. So I think having, the ODESI properly, used as a proper tool, then the doctors could have given us some kind of direction as to how to find somebody or where to go. And I think a lot of the caregivers that I have spoken to over all these years, you're not going to find the first psychologist that you're going to get along with. You've got to find the right personality that's going to be able to help you, and hopefully the person that you're taking them to be helped. And I remember walking out of somebody, and it was the most disastrous meeting. And that alone turned off going to see anybody for at least a year. So here we are wasting critical time. You've almost got to, like, not pub crawl, but psychologist crawl until you find the right personality that you're going to get along with. And from the time we saw that one individual to the time that she saw another, I would say a good 3 or 4 years had gone by, which was heartbreaking. When I look back.
It's a long time.
It's a long time, and it's a huge big gap in support and help. And as Shaleen mentioned before, the longer you wait, the more embedded the eating disorder becomes in the brain.
That's exactly the same thing I was thinking.
Yeah. So I just wanted to also add one thing about what we were talking about earlier before is, I think one of the biggest issues we face is the lack of training for primary care physicians and anybody else working with youth and children. Mm-hmm. Is, more training and support out there for social workers, dietitians, nutritionists, primary care doctors, so that an eating disorder can be diagnosed, and then you can be referred on to the person that can hopefully be able to help you as part of the process.
Agreed wholeheartedly, and I would much prefer a pub crawl to a psychologist crawl. Shaleen?
You know, it just baffles me that there's such a gap between what we know about eating disorders, right? Like that they are incredibly common, very complex. Rapid access to effective care is critical to effectively treat them before they become embedded. They're one of the most deadliest of all the mental illnesses, incredible risk of suicide. We know all of these things. We know that rapid access to quality care diverts people, helps people recover from this illness. And we know that with effective care and support and treatment, that people can and do completely recover from these illnesses. We know all of this to be true, and yet we don't have a national coordinated response to dealing with this illness, which is, I can't get my head around what is the gap. You know, how do we move forward with this, with the Pan-Canadian strategy to connect education, research, funding for supports delivered on the ground, closing those wait lists. We know what needs to be done, but we lack something critical to move that forward.
But why isn't there a strategy for this? Is there a national strategy for this?
No, and we need to work together with community groups, researchers, clinicians, and government. I mean, we absolutely have to work with provincial and federal governments to move this forward in a strategic, collective way.
You think that would be something that could be funded, a national strategy for eating disorders? Anyways.
So I think, Michael, to your point, I think what we know in our field, and I think what many of us are advocating for, is that, you know, eating disorders are underfunded, under-researched, underserviced, and we need a coordinated response. And I think that's a long-standing issue. And there's comparisons out there, and I won't get the numbers right, but if we compared sort of the funding in schizophrenia versus eating disorders, you know, which has a lower prevalence rate, schizophrenia, right, lower mortality rate, they get almost an eight times more funding than we do. And while that's really worth, yes, but very worthwhile research, it should be and, not or, you know, not schizophrenia or eating disorder. It should be and I think there's still similar to ADHD and autism research, where the gaps are massive compared to how much funding they get in those areas. And so I think there's a lot of us here today and sitting around this table who are, you know, coming together as a coalition to really start thinking about how do we create a Pan-Canadian strategy and coordinated response, because so many of this can be done. There's so many of us really excited to do that together. The expertise exists. It's funding. It always comes down to money, you know, but it's funding. And but we're ready, I think, to move forward and have enough data, evidence, and expertise to really push that bucket forward.
And with the 1 in 3, like now we've been relying on incomplete data sets and Australian data. With those numbers, we're saying this is a crisis, that people are dying, and we must act now. And those calls have fallen largely on deaf ears. And now we know 1 in 3 Canadians are at high risk for an eating disorder. We cannot wait any longer. The time for action, it was yesterday. Eating disorders are everyone's business.
Michael, NIED and a bunch of other people across the country were responsible for writing the first national eating disorder strategy. It is a document. It had a 10-year, was a 10-year working document. It has been written. It has been drawn up, but unfortunately, it was never taken up, I guess, by sort of the federal government to sort of take it to the next step, even though 40-odd organizations from across the country came together many years ago to put this document together. I just want to just share one thing, and I don't know if it's appropriate to share it here, but I'm just going to say this because, you know, 8 years ago, my older daughter got breast cancer, and here was Amy struggling with an eating disorder. Thank God, my older daughter is amazing. She's going to be doing an Ironman in Barcelona in a week's time. She's fantastic. But honestly, when my older one got cancer, and every single part of her treatment was rolled out without having to make any phone calls, her whole 5-year treatment plan was laid out, that I remember turning around to my daughter and saying to her, you know, I wish you had cancer, because then you would get the help that you need. And this was in 2016. You know, and here we are to this very day. Yes, she lives at home. The stress on us is awful. and it's just relentless and it's endless for myself and for hundreds and hundreds and hundreds of other caregivers that I have spoken to over the years and that I know who are actually watching this recording. So, you know, I don't get how the powers that be can't see the desperation and the seriousness of eating disorders. I know there's people on this call whose children have died from an eating disorder. You know, eating disorders kill. And I don't know how much more has, you know, like, why do people not wake up to this? It just speaks to the volumes and the sadness of the lack of acknowledgement that eating disorders are a serious, fatal mental illness.
Wow. I had a question that I wanted to ask to follow that up. So I don't really think it's on the list of questions we talked about, but I'm going to ask it anyways. So we've gone and collected this information. And I have said that if we get room again, we'll throw it in again, because it's not a big, terrible 40-question screener. Sometimes space is hard to come by, so I make no promises. But I'm curious, like, where do we go from here? So we have this piece of data. Who can publicize it? Who can make sure that it gets into the right hands? Who wants to look at the intersectionality of this? Are there other researchers out there who are looking for information? As I said, we give this data away at no cost to any researcher because we want to make sure it gets used. So my question is, okay, we've got this piece of information. We've put it out there. Thank you for contributing to allowing for that to happen. Now what?
I can maybe take a stab, but folks jump in. Now what? I think that's an incredible offer, and the first time we have data available like this for any researcher, any organization with the capacity to take this on and mine it a bit further, and we do due diligence to do that. I think a couple of things come to mind is we do have, you know, many of us that are all sort of working together. And so spreading the ability for us to do that amongst the researchers in our group could be one of our first calls to action. But I think what I want to highlight here is I think this data really articulates it's just not the eating disorder field that should be involved in the work that you just said, Michael. It's everyone's business. So folks working in depression should be in looking at the interaction with eating disorders in any way they can, et cetera, et cetera, et cetera, so that it's not just a few of us, you know, a small group trying to push out this data, but it literally becomes everyone's business. And then people start to understand how even the patients and clients that you're serving today might have some of these concerns and symptoms. And what does that mean for you and your service and the families that you serve? And so that they can educate themselves. But I mean, no doubt, do we have opportunities to publish, to spread the word, to use it in early intervention campaigns, et cetera? I think what's really exciting about our field and our small knit group is that we do work closely together. And so we can articulate that amongst us and get it out there. But we would really encourage other sectors and other professionals to jump on board so we learn together.
Anyone else want to take a stab at that? Wendy?
You know, I've thought of, I mean, we've been through so many different sort of thinking outside the box. How can we get this out there? From doing like a full page ad in the Globe and Mail to, you know, putting something on TV. But I just don't think eating disorders are given the recognition that they deserve and that is owed to us, you know, short of sort of taking families or taking caregivers or taking people out of hospital and showing people what they look like in a, you know, to the governments. I don't know. I think it really has to come, you know, I think the community programs on the ground have taken up a huge amount of slack and effort that really belongs in a bigger institute or government-funded organizations. And the community programs get no funding from the government. I mean, that's mistake number one. You know, I think hospitals do a great job if you need to be medically stabilized, but from our experience, a hospital program for us, and I know for probably countless other caregivers, has not been a place for their children to get well. I mean, I'm not talking about children, I'm talking about young adults. I mean, I know that, you know, Nicole is in a pediatric environment, but the caregivers that I talk to are usually with young adults. And if they don't want to tell you what is going on, you're pretty much in the dark because, you know, of this confidentiality issue, which is another whole different ballgame. But I don't know how or what is going to wake people up that eating disorders are a serious mental illness. I don't actually have the answers. I mean, here we had a prime minister whose wife has got bulimia, and nothing kind of happened. Would have been a golden opportunity for something to, you know, have taken place for the country. But I honestly don't have the answer. I mean, we've tried to think and rethink and think outside the box and inside the box, outside the box, and come up pretty blank, you know, other than hats off to all those community programs around the country that are doing so much. People like Shaleen, people like NIED, Body Brave, all these other organizations who are doing so much. Sheena's place to help and support. So I don't know.
Love to follow up with Wendy said with data. What we looked at over the course of COVID was how much these community-based organizations, how much they actually, how much of their services increased because of the pandemic, and recognizing they're not funded, government funded. And the number, when we looked across almost eight organizations across Canada, their services rose by 118% during COVID. 118%, more than doubled the amount of services that they provided, and they're not funded. And so I can't echo more of what Wendy just said. The amount of work that these community-based organizations like NIED, Body, Peace, NEDIC are doing is insurmountable, and we need to ensure that they are well funded to be able to continue that great work.
You know, the community programs spend so much of their time trying to raise money to stay in business, really, that's what it is. They shouldn't have to do that. There should be somebody handing out the money or handing out a grant or something to all the community programs to help us carry on doing the work that we're doing.
So Shaleen, anything you want to add, or you're good? I see you're right in the chat, so.
Yeah, I just realized that I'm messaging away in the chat, and they were just going out to the panelists. So my apologies. I think I'm getting some tech support for those, but yeah, the insufficient funding is a huge challenge across the board, not only for research and clinical programs, but like Wendy said, the community groups who really stepped up during the pandemic. And eating disorders in Nova Scotia is no different, where we're constantly scrambling to maintain core operations and serving literally thousands of people per year.
Michael, maybe I can just say something about your poll, which is astonishing.
Hopefully it's a good thing.
Yeah. No, but just to expand on it, if you think 1 in 3, which I thought it's obviously come down the numbers, because it used to be 1 in 4, Nicole, right? Like many years ago, it was 1 in 4 would be affected by
1 in 3 is higher than 1 in 4, right? So it's gone up.
Yeah, it's gone up, right? So, but when you think of those numbers, that number that's just the person with an eating disorder. But if you think of them having a caregiver or 2 caregivers, then look at your numbers as well. How many people are really impacted by this illness? You know, with a caregiver looking after them, or whether they're living at home or away from home. I mean, we hope there could be 2 caregivers, but it's usually, a lot of the time it's only 1. The number, the impact of eating disorders on the entire family is enormous, from financial to guilt to marriages breaking up, relationships being affected. It's a terrible domino parasite in my mind.
You know, what's a fascinating thought that comes up from that is that we keep hearing things like, mental health costs us $50 billion a year, and then there's an additional 50 million or whatever it is in lost productivity. But if you were able to specifically look at the economic costs of eating disorders, and you'd be looking at things like, like, I know it sounds terrible, but take the human out of it for a second and just look at it from a purely economical standpoint, that if you can do early intervention, because it's such an early hitting disorder, that can last an entire lifetime and happens during critical developmental milestones, you could see that it would have lifelong impacts right away. And I don't think I've ever seen anyone try to put an actual number specifically to eating disorders, which would be a fascinating process to go through, to actually say, like, eating disorders are costing us $60 billion a year in lost productivity, lost wages. Putting aside the moral piece, which I do think is important, there will be absolute economic cost to not addressing these sorts of issues. It's a fascinating question.
Michael, beautiful segue. So many of us also, again, we just recently completed a costing study, an economic costing study here in Canada. We were looking at specifically the cost during the pandemic, because for eating disorders, the surge, what we learned around the world globally was an incredible spike in eating disorders, but we didn't know what was the cost associated with that. And so we got a grant. Many of us 40 plus of us came together. We hired Deloitte Access Economics to help us with this. And here's the crunch line here. We don't have enough data to be able to calculate any of those numbers that you just said. So yes, it would be amazing for us to be able to have those numbers so that we can actually know the costs, which in Australia and then the UK, it's in the billions. We don't have any data in Canada to even approach doing those analyses, and that's where we have to start. And so many of us, the 40 plus people who are part of that economic study, our finding is that we don't have enough data in Canada, and we need a national data and monitoring strategy for us to be able to articulate costs, burden, suffering, etc., and do it accurately.
You may never have enough. You may never have enough data for all of that, but certainly I'm sure a lot of those gaps could be filled. But it's an interesting question. And this is someone who collects data all day and thinks about creative ways you can start collecting indicators like this. That's a fascinating question to put in front of my brain.
It's so fascinating to me, because I think about, we have a sense of like inputs into the mental health care system, so we know, like, okay, well, this province has this many psychologists and this many beds, and they maybe have this many people go through a program, but we don't know necessarily what is the outcomes of those investments in that funding. So not only getting a sense of how many people are impacted by this, what do we know about them and their journey to care? How do we close that gap between onset of symptoms and accessing support? And then how do we scale up and fund programs and treatment that is effective long-term? And there's such a missed opportunity for innovation in this space when we don't necessarily have mechanisms in place to track and measure what treatments are effective in real life for the populations being served.
I understand. All right. In the interest of time, I'm going to move on to the last question. This is a fascinating one for me, though. I think there might be some people on the call who are interested in understanding more about the screener themselves. I know I mentioned earlier in the call, is there any way to share it? But can people use this in their practice? Like, is this an open source project? Can they use it? I know for us, it was not the simplest screener to use because there were different scores depending on how they scored against it. So you had to really understand it. But it wasn't a long screener. So once we understood it, it wasn't actually a lot of work to use it. Once we got over that initial hump of trying to understand what it was actually telling us. Can people use it? Is that something that practitioners on this call could actually use?
Yeah, it's a completely open source, available tool, and we would encourage anybody and everybody to use it. We're just developing a hopeful online training that we can have to accompany the tool, just so folks, have a bit of instruction as to how to use it. And Michael, to your point, I think when you're doing the scoring in the background, maybe the way that the MHRC did it might be a little bit complicated, but an actual version of the screening tool, it's what's a neat part of it is it has a traffic light scoring opportunity. That's, red, orange, and green. Green are, low risk, orange are cautious, and red being in a high risk. And just by simply looking at, if they could visualize the way a young person or a family member might have filled out the Odyssey, you can see in seconds, whether they fall into the orange or the red, and that allows you to know what to do next, whether to ask a few more questions, or whether this is not an issue for this person at this time. And so I think there's better ways for us to be able to potentially make this much more useful for as many folks as possible. But we are hopeful that it provides a tool that people can absorb in their practice. Mental health practitioners, schools, campus health, first responders, emergency departments, sort of everywhere. We're hoping that we can get this implemented in many places and as many as possible. We'll make that available. We have a website that's going to be available October 1st where you'll have access to the Odyssey. And so I'll make sure to put it in the chat here for folks.
That was going to be my question, because I don't like comments that are like, it's coming soon. I'm like, when? I'll make you hold people accountable. October 1st. That's fantastic. Just a week and a day away. So, all right, Shaleen and Wendy, any final thoughts before we move to questions? Nope. Nicole, any final thoughts on any subject before we move to questions? All right, well, we're 2 o'clock. We're right on time for questions. So can I ask, thank you, Brittany.
Hi, everyone. That was a wonderful discussion. Thank you so much. It was a pleasure to listen to. And we didn't get too many questions in the actual chat, but we did have some questions come in by email prior to the webinar. So we'll start with the ones that we got in chat, beginning with one that is actually you just answered, which is fantastic. The question was, who has access to ADESI? And followed by the comment that the challenge is the educational strategy nationally, building capacity to use this and the next steps. So if you have anything that you want to add to that, I know, Nicole, you said it's going to be available October 1st, but if there's anything else you want to add on to the end. Okay, straightforward, perfect. Another question was, do the panelists have any recommendations for preventative programs? And then there were a couple follow-up questions to this as well. I'll add one. Are schools or community organizations places that we should be resourcing and targeting?
There's a program called Confident Me, and I believe it's funded by Dove and run out of a number of places across Canada. I think the YWCA runs it and the Rock in Ontario. So Confident Me is a program. There's also an evidence-based program out of Stanford called the Body Project. And that is designed predominantly for young women in university settings, but that's another evidence-based program.
And neat enough, Ontario and our provinces, of course, are very different as it relates to eating disorder services, with Ontario being very rich. And that's maybe a point we should make here. You know, Ontario has 49 eating disorder programs. Some of those are satellite with a half-time person sort of manning that fort. And then there's other provinces like New Brunswick that have 0 programs. And so the disparity is massive. So in Ontario, we are considered, rich that way. And there has been in the last 4 years an investment for prevention services that's being led by Dr. Gail McVeigh out of UHN, the University Health Network. That's called Eating Disorders Ontario Prevention. And they are laying a suite of prevention efforts across Ontario, starting in schools, public health, working with families to try to get prevention across the different realms of prevention on the ground with some government funding to back that up. And we are hopeful that we can show some great outcomes with that if we had the funding for both prevention, early intervention, and intensive treatment, in Ontario, to showcase how really doing that whole continuum is the sweet spot, is the magic we need to actually, kind of tackle these high prevalence rates. So that program, there is a website for that. I will also share that, but Eating Disorders Ontario Prevention, where they mention all of their different prevention activities.
Thank you. And I also just want to note, due to some technical difficulties on Zoom, our panelists haven't had the opportunity to address everybody who's attending with their comments. So any links that would be relevant to this conversation, we will be sure to gather them up at the end of this webinar, and we can send it out along with the recording link, so everybody can make sure that they don't miss out on any of these resources. I
see some of our comments that Shaleen, some of the comments you put in here. I'm going to hold, you put to host and panelists. Did you put to everyone?
Yes, it's the option to comment to everybody. For some reason, I think it's the new Zoom updates hasn't been available to our panelists, unfortunately, for this one.
Technical challenges.
Thank you for copying some of the key ones and putting the links in there, please.
Sure.
So I'm just going to dive into some of our online questions that we've been getting. There are a few of them. Some of them are repeats. So, there's no time frame for these questions. Feel free to take your time, as much or as little as you'd like. One of them is quite broad. It is, how can friends and family best support somebody with an eating disorder? So I don't know who wants to start off taking this one.
I don't mind. I can start. I'm sure everybody else can add their bits to it. I think one of the most important, I know when Amy was first diagnosed, I didn't want her to be labeled as, you know, she has an eating disorder. So we told some of our closest friends, you know, what was going on with our lives. And also, I guess I was fortunate in that I didn't feel that we were being stigmatized. I know stigma for a ton of families is a huge, big issue, but I personally never felt that. I didn't feel like we were being stigmatized, but I didn't want her to be looked at any differently from my other two children. You know, we just wanted her to be part of the family and for nobody to label her. Like, I'm so weary of labels. And I think for family and friends, I know that there are some people who's, you know, when you've gone away on a holiday or where you are meeting other people, I've always sort of tried to beforehand just say, you know, don't make a comment on how people look. Don't talk about being, you look healthy, because sometimes that word healthy to somebody with an eating disorder can mean I'm fat. So talk about from the head up. Say nothing from the neck down. You know, your eyes are sparkling, your hair is shining, you know, your eyes are beautiful today. So don't make any comments about how people are looking or how they, you know, you look well. Those kind of comments can have very sort of triggering, and it can mean something totally different to what you anticipate the person understanding. So just be wary of your language. Don't talk about, you know, I don't know, losing weight in front of other people. It's just, those kind of comments are just not comments that need to be made in public. You know, think of it yourself, but just think of your wording before you say something to somebody. You know, the other day, Amy went to buy a bagel at a store, and innocently, you know, she has gained weight, and yes, her face looks amazing, and she's just such a different person than she was 5 years ago, even a year ago. This time last year, she was disastrous. And the person in the bagel store said to her, "Are you pregnant?" You know, because her tummy was a little bit distended. She came home devastated, absolutely devastated, that somebody had, and it was somebody who was just probably thinking, well, she's coming to the same store every day to pick up the same bagel. Maybe she's got a craving. That's the way I kind of try to interpret it for her. But I think people and society and conversations generally need to change. I can just tell you one amazing experience I did have. We were downtown in the summer, downtown Toronto, and the waitress came up to us, and we thanked her for, you know, the meal, and she was so nice. And she made a comment. She said, "Since I've been working here, I've gained so much weight." And it broke my heart. And when she came back with the bill, I actually took her arm and I said to her, "You know what? Don't talk about that. You've been absolutely amazing. You've got a job. You're working so well. You've made us so happy. Don't talk about, you know, how much weight you've got." And I said to her, I'm talking because our daughter has an eating disorder. And this poor young girl, I could see her swelling up in her eyes. And she said to me, "I've had an eating disorder myself." You know, so I think just acknowledging people and just, I don't know, change the conversation, leave the conversation if it's not even good for you. So I just think those kind of words can be so damaging.
Does anybody else want to jump in before we get into the next question?
I just wanted to add, and absolutely, Wendy, that's just the experience of so many of those in our community, and the stories go on and on about how they've had these, you know, happenings in the world that are, you know, benign to some, but have a lot of meaning for those with eating disorders. I wanted to add, in addition to friends and family, what we could do is use something like the Odyssey or any other, you know, screening tools to inform medical professionals and medical professionals across so many realms, including somebody had mentioned in the chat, you know, dental professionals, etc., about how you can ask those questions in a hopefully non-stigmatizing way, you know. And so that's another form of education of how sometimes we've heard from discussion groups from across Canada, professionals say we just don't have the language, we don't know what to say, so we say nothing. And that's damaging on its own. And so, you know, using tools like the Odyssey or any other tool that gives you the language would be really helpful, I think, when we think about supporting.
Thank you very much. And moving on to another question that we've gotten in the chat. It was, if the sufferer doesn't want help and has to obey what would be seen as the eating disorders rules, how can I, as a mom, begin to help her?
How doesn't obey the rules of?
I think it was what's seen as the person with the eating disorder, the rules that are kind of they're seeing as what they have to follow due to the illness. And if they don't want help because of this, how can their mother begin to approach helping?
Well, I don't know. What I share with families and caregivers is to get help for yourself. You know, I think denial can take years and years and years. And if somebody doesn't want to listen to some rules or instructions, depending obviously on their age as well, if they're a young adult, you can do nothing, basically, unless you are really concerned and you need to call 911 or police or ambulance, or if things are getting dangerous and out of hand. But if they don't want to follow rules, I just always suggest to families for you to get help for yourself, because this is a very complicated, difficult illness to try and work out on your own. You shouldn't feel alone. That's another big, huge issue. You know, unfortunately, we're not unique. We're not going through this by ourselves. Eating disorders take a lot of help and support from other people around you. And even if you've got 1 or 2 friends, it's better than 10 friends who are going to sort of come and go in your life. But if you've got 1 or 2 people who you can really rely on, I mean, that's what we did. And we had to go and get help to make sure that you and somebody else hopefully can be on the same page, on the same line, because it's very, very difficult and it's a huge, major challenge.
Just really want to echo what Wendy's saying, and Wendy, you do an amazing job with the support that you provide through NIED. We have a family peer support group as well that meets every month and has education sessions as well. So thank you. The link has been shared in the chat. So really, you know, connecting with your community and finding your peers, and connecting with other parents who have been through the same thing, because we can't do this alone.
Sorry, muted. The next question from the chat was, what can we all do to get caregivers involved in appointments with their adult loved ones? And how can we advocate for changes of confidentiality?
Well, that's a big one. Shaleen, did you want to say something before I jump in? I was just fortunate, and it was really Amy who wanted me to sit in with appointments. At the time when she was going regularly to see her psychiatrist or doctor, she was too sick to hear anything that was going on. So she asked me to please sit in with her so that I could hear or speak on her behalf. So I really just think it happens. You have to just take each family, you know, as they are, and ask your child, ask your loved one if you can sit in. All I can say is no, but if you've never asked, you don't know. And you can always say to the doctor, you know, so-and-so wants me to sit in with them. You know, I've also heard of parents sitting in with their loved one, with the doctor, and also being told to leave, that the doctor wants to see the child or the young adult on their own. And that's a really tough one as well. When the doctor's asking you to leave the room and your child or your loved one has asked you to sit in on the room. So I was just grateful to Amy that she let me sit in with her for a really long period of time. I mean, I'm talking about years. So it depends. I think it depends on the child, the young adult, what you can do, and your relationship with the doctor.
Thank you, Wendy. Shaleen, did you want to add to that at all?
I just put a link in the chat. There's a group in Canada that's looking at trying to advocate for changes to some of those rules around patient confidentiality with kind of an inter-provincial lens. So I just shared the link to that in the chat too. There it is. Yeah, but like Wendy says, you know, it's like there's changing the rules, which is this huge thing that when you're struggling with a child with an eating disorder, when you have one, like that's one battle you want to fight. So really reiterating what Wendy's approach of, you know, advocating for your daughter with her, you know, having that united voice together. I think that's a great advice, Wendy.
Yeah.
Yeah.
Thank you both very much. If there's no more comments on that question, I can move on to the next one. It was another one that was emailed into us. And it was, what are common myths and misconceptions about eating disorders that need to be addressed?
I keep forgetting that my mic isn't muted. It's for me whispering to myself. Oh, okay. So I'll just go rapid fire. You guys jump in. So everything we thought we knew about eating disorders, like from 20 years ago and the after school specialist, is probably wrong. So eating disorders impact people from all different backgrounds, all different body sizes and shapes. Restrictive anorexia nervosa is the least common of all the eating disorders. So you can have bulimia, atypical anorexia, binge eating disorder. These are all equally valid and soul destroying illnesses. Everyone deserves care. What we're also learning last few years is that intersectionality piece. So folks who are trans, non-binary, LGBTQ plus 2A, much higher risk for developing an eating disorder. We know those eating disorders aren't like dieting gone wrong, but are actual brain-based, metabolically fueled mental illnesses. We've seen brain images and scans showing differences in the brain between folks with and without an eating disorder. We know that nutritional rehabilitation for anyone who has been restricting is critical to brain function and recovery. And we know that these are very complex illnesses that take a long time to recover from. So, you know, 6 days of treatment, 6 weeks of treatment isn't sufficient to recover from the illness. It's a nice push, but we know that care and support is needed over the long term to keep that eating disorder in remission. Okay, next. Nicole.
That's a loaded question. There's so many. I feel like there's like, we need an FAQ page just to kind of address all of them. But I would echo, I think we all have very similar sort of things. Eating disorders don't discriminate. I think 20 years ago, everybody thought eating disorders were only affecting, you know, young Caucasian females. And that's sort of the ongoing persistent thought. And so, you know, we know eating disorders don't discriminate, not only in the and some of the groups that Shaleen spoke about, racialized, ethnic minorities, lower SES groups, you know, and what we don't know and what we do need to figure out is how do we better serve those underserved groups and make sure our treatments apply to them and that they can see themselves in that treatment and how they can access that. Other myths, oh goodness gracious, that it only affects the young people. There's many 55 plus adults who are just on their first path to an eating disorder, and they equally need attention as the young people do. Oh my goodness, I can go on and on. Wendy, jump in. Let me.
Yeah. I think we also need to know and really be aware that eating disorders affect boys and males and men. You know, that's a huge. I know there's somebody on the call here in the group here who had a son that didn't make it, and you know, so I think it's so important to also realize that young boys are also extremely affected. I think it's gone up something like 400%, Nicole. I mean, if I'm correct, in males and boys and men. So we have to really be aware of those as well. You know, be cognizant of that as well. Yeah, I think you've both covered all the everything else's.
And I just want to say, I think we have an idea or historical idea of what an eating disorder should look like. And it should be the really emaciated body, you know, and those are the only people with eating disorders. And it couldn't be so much further from the truth. And so just by, you know, providing education that anybody could struggle from an eating disorder and moving away from just thinking it's only those in emaciated bodies would do our field a world of good.
I think also I want to also add that that I didn't realize until we started getting help ourselves was that eating disorders are genetic. And 80% of it is genetics and 20% of it is the environment, which is a huge number. And that, Nicole, I know that you could back this one up, but that eating disorders are not just affected by one gene in the body or in the DNA, it's multiple genes. So that's why the complexity and the complicatedness of this illness is so complicated. You can't just take one medication to stop an eating disorder. It's not going to work like that.
And absolutely, and knowing how much hereditary genetic risk is associated with an eating disorder, we have no funding to understand genetic studies in eating disorders. In Canada, we have had very limited funding, although so much interest and so much need. Again, it's in one of those other unfunded areas that requires a lot of learning for us to really be able to understand.
I feel like in many ways, Nicole and Wendy, like our hands have been tied for the past 30 years in trying to address this illness, and people have been suffering immensely and unnecessarily because of the lack of funding.
Yeah, I think what also struck us, should I carry on, Brittany?
Absolutely. We only have one more question left from the email, so if you want to follow through with this is great.
I just think that when we first started going to our therapist, and she was the one who actually helped me found one of my co-founders from NIED, Patsy Perry. Some of you on the call probably remember her. She made my husband and I look at our family history of alcohol or anxiety or drugs or smoking or suicide. And it was quite horrific for my husband and I to start filling this in and to see how many people in our family were suffering from one of these other forms of mental disorders or disabilities, or the substance or suicide. And for Amy, it came out that she was predisposed for an eating disorder. That's what happened to her. She didn't become a smoker or a drinker or things like the other addictions that are out there. So for her, when people made comments, it just sat and brewed in her year after year after year after year until it exploded into an eating disorder. But for other people, it could have ended up as a different kind of an addiction. So, it's quite nerve-wracking when you start looking at your ancestors and to see, maybe.
There is a genetic component in a lot of mental illnesses that, I think we've seen a lot more science in this space in the last 30 years, certainly. So, Brittany, I just want to make sure we have time for this last question as well.
Yes, we do. We have a couple minutes left, and I think it is a good wrap-up question. Wendy, you commented on how important it is for caregivers to take care of themselves while they're caring for their loved ones. So the last question that came in actually was, what are self-care strategies that caregivers can adopt to manage their own emotional and mental well-being?
I think, you always hear, take care of yourself so you can take care of somebody else. But more often than not, it's easier said than done. And I think we've got to find a gap or some space or some time. Fortunately, I love being outside. I love going for walks. I love doing yoga at home. I swim. So when I've got those, and I've tried to build that into my life, just to give myself some space, because honestly, otherwise, we would be drowning ourselves. And thankfully, we've got a marriage made out of cement, so that's been brilliant, and I'm so fortunate, and I count my blessings. And I really think that as hard as life and our time and our daily living, really daily living, I'm talking about stress 24/7, is with us, I still can count my blessings. I can still, just enjoy just being outside, going for a walk, doing mundane things. I'm not one for, doing complicated stuff. So, and just working with other caregivers and having founded NIED really for me has been part of my own therapy, just to know that our organization has made a difference in other people's lives and that I can talk to other people without taking on their stories and without getting emotionally involved has been a big help for me as well. And I I found it empowering. Did they answer the question?
That was a great answer to the question. Thank you so much. I'm going to hand it back over to Michael to wrap things up.
Well, I just want to start by thanking Wendy, Shaleen, and Nicole for your participation today. I just want to remind people that it'll take us usually about 2 or 3 days, but we will get this webinar posted and make sure that the deck is available as well. And as always, if you have questions, you can always reach out to us at info@mhrc.ca. Certainly I know Wendy and Shaleen and Nicole have always been responsive to emails when they're sent as well. Are there any other critical questions or comments anyone wants to make before we wrap it up?
We'd like to thank you, Mental Health Research Canada, for doing this, for taking this on and allowing us the space to talk about the data, showcase the data, and making it freely available. This is a huge step in our field, and so we're incredibly thankful.
We appreciate that.
Thank you so much.
Thanks so much. All right. Well, thank you everyone for joining us, and we'll hopefully engage with you again soon. Thanks so much. Have a good day.
Thank you, everybody.
Bye.